Okay, we're recording. And I'm admitting everyone. Good morning, everybody.
Good morning.
Morning.
Hey, Mike.
Hi, Joanne.
Oh, we got Sarah. I'm just giving everybody a couple minutes because we've got another minute to get started. So we'll get everybody in. If you're not muted, can you please make sure you're muted? Okay. All right. I think we can get started. My name is Grace Peeler, and I'm the operations manager at McCavan Care and Prevention Network, and we collaborate with the SafeRx Coalition of Mendocino County. Hello, everyone, and welcome to today's session of Addiction 2021, Treating the Whole Person, hosted by SafeRx Mendocino Opioid Safety Coalition. SafeRx Mendocino Coalition members are medical professionals, educators, law enforcement, and community-based organizations, taking a community approach on preventing and reducing opioid misuse and stigma, and promoting holistic and comprehensive treatment for a healthier community free from opioid misuse. If you're interested in joining our coalition, please add your email in the chat box. Visit our webpage for more information at www.saferxmendocino.com and find us on Facebook, Instagram, and Twitter. We're going to start with a few housekeeping items. First, if you want to minimize your video so you can see the slides that we're sharing, you can go to view options at the top middle of your Zoom to hide the video panel. So that way you can see the full PowerPoint. Oh, I'm letting some people in. Give me a sec. Okay. If you have questions on how to receive continuing education credits, please privately chat one of our moderators today. So that's going to be me, Grace Peeler, Buffy Barasa, and Al Hassan, and Joanne Gamble. Mute yourself during the presentations, and the session is being recorded. There will be an evaluation link in the chat box at the end of the session. Please take the evaluation and let us know how we did. We'd love to hear from you. Your feedback is a requirement to obtaining the CEUs or CE credits, and we will send you a certificate of attendance as well. So our agenda for today, I'll let you guys take a little look, and then we're going to watch a video. Okay. And next we're going to watch an anti-stigma video.
Grace, were you going to do the introductions for Dr. Herring and Cara?
Oh, I wrote it in the wrong spot. Yes, I am. Sorry, guys. So we've got our keynote speaker, Dr. Andrew Herring. He's an emergency physician and director of emergency pain management and addiction treatment at Highland Hospital, Alameda Health System in Oakland, California. Dr. Herring is an assistant clinical professor at the University of California, San Francisco, and obtained his medical degree at Harvard Medical School and conducted health policy research as a Fulbright scholar in Central America. He trained in emergency medicine at Highland Hospital and is board certified in addiction medicine. Dr. Herring conducts research on health policy, addiction treatment, and non-opioid pain management approaches in the ED. He is a member of the American Academy of Pain Medicine's advisory panel on acute pain medicine with an interest in bringing the highest quality multimodal pain management addiction treatment to the emergency department. Dr. Herring is leading a CHCF-funded series of pilots to launch provision of medication-assisted treatment for opioid use disorder in emergency departments throughout Northern California. Today, we also have Dr. Cara Eberhardt. She's going to present to us about No Wrong Door and MAT access in healthcare. She is a first-year resident physician at the Ukiah Valley Family Medicine Program. FMRP is a new residency program created in affiliation with UC Davis to improve access to primary care for patients in Mendocino and Lake counties, while training the next generation of physicians to meet healthcare needs in rural communities. Cara graduated from UCSF School of Medicine in 2020, where she co-created the Harm Reduction and Addiction Medicine Interest Group and co-wrote a curriculum for the first Harm Reduction and Addiction Medicine course for medical students. The elective partnered with several community groups and addiction medicine fellowship trained physicians to provide a foundation for identifying, treating, and destigmatizing addiction. Prior to medical school, Cara spent 6 years working in substance use disorder counseling and care coordination in the Bay Area. She's excited about the opportunity to work and train in Mendocino County and grateful for the warm welcome she has received thus far. And now we're going to play you a video. I will give you a little overview before. With the rising addiction issue in Mendocino County, it's become apparent that shame and discrimination are associated with people who use drugs. In light of this, Mendonoma Health Alliance, in partnership with SafeRx Mendocino, developed an anti-stigma media campaign. Let's take a moment to watch the following anti-stigma video featuring Mendonoma Health Alliance, Mendocino County Public Health, Adventist Health Round Valley, and community members before Dr. Andrew Herring speaks.
We are in Northern California and it is beautiful here, and we have dealt with the same thing that everyone else is dealing with: racism, health inequities. Homelessness is high, people are out of jobs, and substance abuse is really affecting our entire community.
Studies have shown that approximately 60% of addiction is genetic predisposition. So there are many triggering factors that can lead to addiction. People suffer from depression, or simply people suffer from other psychiatric disorder, put them at higher risk for addiction. Prescribed opioid medication is another gateway. And of course, environment can also be a factor.
Isolation is a big part of addiction here. This community is, a lot of us are like spread out, and they use alcohol and other drugs to cope.
I became addicted to opioids after having spinal surgery, and I started taking medication as a result for the pain, and was addicted to them in total for a year and a half. I thought stopping the drugs would be easy once I decided I was going to, and I was having physical reactions that I could see and feel when I wasn't getting the drugs. So it was harder than I thought.
By the time I was 12 or 13, I was smoking meth with my mom, and I was using every day after that. And it was really hard to imagine having a day without being high. And I went through several different foster homes my last year and a half of high school. And the last home I was in were foster parents who were a little bit hippie, a little bit rock and roll, and without their unflinching love, especially in the light of my most awful behavior, I honestly think that I may have killed myself either accidentally or otherwise. My life today is such an incredible miracle, and it is never lost on me. I'm in my 27th year of recovery, and there are still some days where I stand at my kitchen window and I look outside my backyard and I'm struck with disbelief that I live in a safe home with my sons who are safe, who have everything they need, who have never seen me loaded. My life is incredible.
Many people experiencing addiction do not seek help because they feel shame about their addiction, and they're concerned about being judged by their friends and their family or the general community. So it really, stigma surrounding addiction and it being their fault prevents them from getting the help that they need.
Oftentimes, stigma becomes a barrier. So if we want to see a successful outcome, we have to start from there. Our role here in our community is really to educate everybody more about what is addiction. We need to let people know that the earlier that we can start the intervention, the better outcome that we are going to see.
Freshman year, high school, I got caught smoking marijuana on campus by like our favorite teachers. So that was pretty shameful. I got expelled from the school, so I went into depression. I got back into school, played sports, but I still drank, I still smoked, and then I think eventually I used meth. One night I overdosed, that really took me really by surprise. It really woke me up to realize that I could have lost my life, and it really helped me realize that I need to stop abusing myself. My body, my spirit was telling me that I have a bigger purpose to serve. To be able to recover here in my own community at home was the best thing, because it really opened my eyes to what the true meaning of being a community member, being a family member, being a friend, being a husband really means. The life that I live today is amazing. I'm thankful to be able to experience fatherhood, be able to experience being married for almost 12 years. My mind and my heart is open. I feel connected. Through recovery, that's possible.
If you're a loved one of somebody who's struggling with addiction, I think one of the first steps to do is reach out. Let that person know that they're loved and cared for, and let them know that you're not going to judge them for the choices they've made in their path.
When someone is ready to ask for help, there are definitely resources in our area, and with Mendonoma Helplines, we can help you get connected to those services. It can be online, it can be in person. We're here to help.
If you're a person experiencing addiction, I want you to know that you're not alone. Mendonoma Health Alliance is more than ready to help you find the resources to jump those obstacles that are in front of you.
Addiction is not a choice, and it doesn't define people.
Como hablamos de las personas que usan drogas, importa.
I am not my addiction.
We can overcome addiction
Together.
Okay. Dr. Herring's running a little bit late, so we are just going to maybe go around and introduce the folks that have worked on this project with SafeRx Coalition. You guys already met me, Grace from McCavan, but Buffy or Joanne, if you guys want to just introduce yourselves while we wait for Dr. Herring. Oh, here he comes.
Oh, sure. Hi, I am Buffy Wright-Barassa. I am a senior program specialist with Mendocino County Public Health Community Wellness Unit. I am the facilitator lead for SafeRx Mendocino Coalition. Thanks.
Hello.
Hi, Dr. Herring.
Hi, sorry, for whatever reason, I had to restart my computer. It just wasn't
That's okay.
liking that link.
We're happy you're here.
Yeah, so am I.
So welcome. We already did your introduction. I can bring your slides up, or if you want to just
Here, let me just pull up. I can just pull up my slides. That's okay. 2 seconds. Everything had to shut down.
While Dr. Herring's bringing up his slides, my name's Al Hassan. I'm the clinic administrator at the New Life Clinic, soon to open up in Ukiah, and it's been a pleasure to work with the team that's put this all together.
Oh, wonderful. If the administrator or moderator would allow me to share my screen, I should be good.
Oh, perfect. Okay, you should be able.
43 here. When did we want to wrap up the slide presentation and have time for questions? We have time for questions.
We had you slotted for about a half hour, and then questions around 12:15, if that works.
Perfect. Fantastic. That's great.
Okay.
Okay. So I am really thrilled to be here. This is so fun to get to try to connect with people around the country, around California, doing good work, helping people who are struggling with their drug use in all the various forms. And so today was really asked to talk about the idea of sort of whole person care and destigmatizing care. So so we'll kind of get into that. And we'll see. We'll take that journey together. The disclosure I have is I'm the PI for. I'll just go through it. I'm the keeps there. So first of all, disclosure. I'm an ER doc. So this has been a journey for me. I certainly didn't initially train in addiction medicine. I did have a little advantage. Before med school, I worked in community mental health, and so at some level, working with folks struggling with mental illness and drug use is what brought me into medicine in the beginning. But then I sort of left that way behind and got pulled into the whole medical world. And so this has kind of been a big journey back to where I began, to thinking about people. I'm also director of our outpatient bridge clinic. So I work in the ER. I also see patients, and we have a really busy specialty outpatient addiction clinic with doctors and therapists and psychologists doing alcohol and stimulants and opioid, both short-term, interim, as well as long-term addiction treatment. I'm the PI for the California Bridge, which is which I think all of you are familiar with, and I hope it's been helpful to you, because that's the goal. And cabridge.org, it's got all kinds of information about that. We started out with 1, 2 hospitals, then 12 and 52. We're going to 200 in the next year. This is mostly important because it means that at some level, I've seen a lot of people, meaning that when things go right, things go wrong, I learn about it. So I've been able to look at physicians, therapists, social workers, nurses, techs, different patient populations from the border with Mexico through all the major medical centers, urban, rural, all the way up into the north, with you guys and to see what works, what doesn't, what causes trouble. So it's a broad background of experience that I can draw on to try to help you with your goals here. I'm also connected with something called ED Innovation. So this is a NIH-funded trial of an injectable version of buprenorphine. So it's pretty cool. It's like you just give an injection under the skin, and it lasts for 7, 14, 20, even 28 days, depends on how much you put in. And we're doing that in the ER. Really more interesting than the pharmacology product is the cool research team I get to work with. So I work with people all over the country. So not just within California, but all across the country. There's 30 different emergency departments, each with our own, really interesting local circumstances that give me one more lens to kind of look at what works and what doesn't. And so finally, this is where, I became a doctor, here at Highland, which is a urban county, inner city, safety net hospital. with almost all of our patients, 80, 90% are on Medicaid. About 40% are African American, 35% Latino, and then a real mix of Asian and white make up the rest. So this is sort of like day-to-day clinical environment. It has been since 2008, and I've been doing work in Oakland since for over 20 years. I do academic work, so there's some real nitty-gritty we can get into around how buprenorphine works. Which I'm going to kind of skip over. But then the other sort of disclosure is I really very much believe that we as clinicians need to start moving into shaping rational drug policy. For me, that means that we need treatment and not criminalization. And that's what I would encourage you as clinicians to really be reflecting and be critical. Maybe it seems like a good idea to you, or maybe it doesn't, but just being engaged in the debate around what is the appropriate intersection of law enforcement and drug use is something that needs the voices of people who are deeply dedicated to helping people. So the basic insight here, I think, that was somehow got lost was very well articulated, has been for a while, by Hart. Hart is a fascinating guy who I have a couple connections to who has written two books. He is a well-known researcher of drug and alcohol use disorders. He was the chair of psychology at Columbia University and is really pushing a very provocative, kind of agenda with his most recent book is Drug Use for Adults. There's a lot of it that a lot of sort of statements around that are again provocative. They're really pretty wild. But at the core of it, all he's really saying is that drug users make rational decisions. And that might seem obvious, but it really hasn't been how drug policy and treatment has played out, in that there's been sort of an assumption that once you are exposed to a drug, methamphetamine, cocaine, heroin, street oxy, that suddenly you lose the capacity to make rational decisions, and everything is driven by this out of control urges and cravings and addiction. And what he's saying and what he saw and experimentally with that just wasn't the case. So for us, what this means is that it's not about catching wild people and forcing them into obedience to what they should be doing. That model, it just didn't work. And it left everyone feeling terrible. It left, I participated in that kind of work, as an ER physician before I really kind of developed a consciousness and understanding of drug use disorders. Like this idea that, hey man, you're just experiencing the results of your own poor decision making. You need to be forced into treatment. You need to be arrested. You need to, just face the facts, that kind of thing. Versus really kind of starting from, okay, if I was in this person's shoes, if I were using drugs, if I were using heroin, if in the specifics of it, if I was using street, if I was buying pills from my buddy, and I was in that situation and I knew it was, and I wanted to stop, what would I need to get out of there? Do I need another place to live, where I cannot be exposed to cueing, triggering behaviors? Is it that I need a medication to keep me from being in withdrawal today, now? What is it? And just walking through and then presenting that case back to the person to really try to entice them to make a decision that moves them from harm towards safety. And that is the behind all of what I'm going to say following. So I'm going to walk through about what this really looks like. just talking about some of these great photographs that we have. So let's say your hospital, and I know that a lot of you aren't necessarily hospital-based providers, but this could as well apply to your clinic or whatever. The key thing is this concept of just the vibe, and it really matters, right? Because most of the people that we're bringing and engaging into care for addiction, use disorders, don't have an existing strong relationship with any institution besides someone who's, the jail or law enforcement or something like that. There's certainly lots of exceptions, but a lot of people don't have a strong relationship with a doctor or a hospital or a clinic. And they're constantly so vigilant for signs that their best interests are really not being thought of, that they're being manipulated, that they're being controlled, that you're just checking a box so that you can get paid. So that authenticity, that spirit of friendship and inclusion is just the floor that you need to build everything else. You can have the most incredible workflows and most amazing therapeutic options, but if the heart of the program isn't there, if people feel like you're just doing it to get through the day and that you don't really care for them as people, they're not gonna engage. From a really more rigorous scientific standpoint, the concept here is one of belonging. So belongingness, so the sense that you are of social inclusion and belongingness is one of the strongest predictors of suicide risk. So if you feel like you belong, then you are much less likely to commit suicide. Conversely, if you feel like you are a burden, you don't belong anywhere and you're just a burden to everyone, you're at relatively higher risk for suicide. So whatever program you're setting up, the first thing is, can you make someone feel like they belong? And to do that, right, you can't judge them. You have to accept them how they come. So right now we're looking at this picture and you can imagine sort of reflecting back, like, who are they looking at? If the person coming to them might have not showered in 2 weeks and have a shopping bag, or a shopping cart full of stuff, or they might be angry because they're in withdrawal and they know that they just screwed up and they lost their boyfriend or girlfriend and they're going to get fired from their job. You don't know any of that stuff. All you see is them coming at you, looking grumpy and saying, "Why am I waiting so long?" And you have to sort of approach it with that compassion, that openness. And that's how you get them in the door. That's how you start. So paying attention to things like many clinics have separate staff that do things like evaluate insurance status. That becomes this mechanized process where before the clinician ever even sees someone, they've already had a meeting with the staff person who's evaluated their insurance. That is a really stigmatizing, complex, difficult conversation. So if it turns out that you have the nicest doctors and nurses in the world, but the person that asked them about their insurance status is brusque, is demanding, and expresses through their physical, through their posture and facial expression, judgment and disapproval, you're gonna blow your whole clinic vibe and people will drop out. Right, and that's what we're just fighting against, is dropout. So paying attention to every single interpersonal contact that someone comes into is really crucial. So once they've gone through the greeting, this is our triage. So the key things here, besides just smiling faces, which really mean a lot, is I want to draw your attention to this sign here. So it doesn't say, do you want recovery? It's not euphemistic. It's not vague, right? It uses real language in the sense is, do you need help with pain pills or heroin? Ask about trying buprenorphine. And the key here is, it's not saying, sign up for recovery. It's not saying that you need to join a program, that you need to enroll. It's it doesn't expect anything. It's really an offer, so that the person has, almost like you can imagine, a hesitant person can just try something. And then you just let them try with no pre-established ideas of like, okay, if you're going to get buprenorphine from me, that means that you're going to not use, that means that you're going to follow up with Dr. Bob. That means, that you're committed to this long thing, and you're going to sign an opioid use agreement, and you're going to follow up on Tuesday. All of that stuff, just throw it out. What we need to do is expose people to treatment, to friendly people with effective medications. So just getting someone to try buprenorphine, no questions asked, that's really the standard now. That is the definition of low threshold care. And it's what you really want to have at every touch point in your system. Whether you're at the jail, whether you're at the FQHC, whether you're at the urgent care or the hospital, the dental office, the surgical offices, everyone should basically have a sign like this, because the prevalence of opioid use disorder and addiction and dependence is so high that you just don't know who's going to respond to this sign. We've had some unbelievable cases. One early case that really drove it home for us was a woman who comes in with her 6-year-old or 8-year-old daughter who's twisted her ankle. She sees this sign. She gets care for her daughter. And then a week or two later, she comes back by herself to initiate buprenorphine, because it turned out that she had had a gynecological procedure at another center. She'd been started on Norco. She was told to get ahead of the pain. She used Norco. Then the pendulum swung and she was cut off Norco. She lived in a neighborhood where Norco was easily sold all over the street. She started buying it off the street. The street supply dried up. And someone said, well, hey, I don't have Norco, but heroin is just the same thing and it's much cheaper. And next thing you knew, she was dependent on heroin and didn't know what to do and didn't know where to go for help. So these signs have been one of the most effective single interventions we've done. And then finally, this is Danae, one of our physician's assistants. And she's in the fast track area, and she's holding up what we call our menu. And so this is our workflow for actually administering buprenorphine. So when we're talking about initiation or induction. And the key here is that it's not a fixed algorithm that we came up with and then told all the physicians to do exactly this. It's an interaction between the provider and the patient that is driven by that patient's choice. Now, some folks know everything there is to know about buprenorphine. Other folks, there are new to it. So there's going to be a huge variation in the degree to which you shepherd and guide people through the process. But the basic standpoint is you get them started with a little buprenorphine. And then you just talk them through, what's their use? Are they someone who has a really, really heavy habit, that they're just deep and they've tried buprenorphine before and now they're using 2 grams a day of fentanyl. If you give that person just a little smidge of buprenorphine, it's not going to do anything and it might just make them worse. Whereas if you have someone who's just using a couple of Norco a day, then if you give them a whole bunch of, big dose of buprenorphine, they're just going to feel a little groggy and dizzy and zoned out for like 4 days. So having that interactive approach is very effective from a dosing standpoint, in that a one-size-fits-all approach will inevitably underdose some people and overdose others. And 2, there's a thing called choice-SIBO. So basically there's the placebo effect, there's nocebo effect. And the choice-SIBO effect is basically, as every fast food restaurant knows, that if you're given a choice, you then have an enhanced positive reaction to whatever that choice is. So if someone says you can only have vanilla ice cream, you're like, oh boy, I wish they had chocolate. If there's a choice of chocolate, vanilla, and strawberry, and you choose vanilla, you're like, oh God, thank God they had vanilla. I love vanilla. So giving people empowerment and choice is not only just something that's fun and rewarding and promotes that idea, that big picture idea that it's all about social inclusion and belonging and engagement, it also just scientifically works better. So then you come into actually, you got to get the drug, you got to get the treatment into people, right? So, this is these wonderful photographs that I just was very fortunate to have of our practice. And it's about this idea of low threshold, where when appointments, these are in them, just a single thing, appointments are the enemy. So if you are trying to engage folks like this gentleman, who lives in an encampment with his girlfriend, you're gonna lose them. Like you have to use drop-in schedules. And this is not easy. It means that your given providers can get slammed. All of a sudden they've got 18 people to see in 4 hours because Tuesday was the day that everyone decided to come in. It's not easy to set up. And so you have to plan for that. How do you manage surges? How do you manage the waiting room if you don't have a nice organized appointment flow? But it is what you need to do. So drop-in appointments are what you need to be able to bring to people. And you have to figure out this next step of how do you go from prescription to actually the actual medication getting into them. So thinking about overcoming insurance barriers, using substance use navigators that can smooth over all of these friction points in the system is really key. And then finally, with many of our folks, it's to remember that they might not be in a point where they're interested in the medication treatment. And that is perfectly fine. Because, and in fact, at any one given point in time, if you think about it, if you engage someone and expose them to the treatment, to buprenorphine or methadone, in 30 days, the majority, so 60, 70, 75%, depending, of those folks will have discontinued treatment. So if in the total, that cross-section, that moment in time, let's call it 30 days, most of the people that are in your community, if you're saying like, okay, my job is to take care of the community of people using drugs and make them as safe as possible, the majority of the people in that community at any one given time are actually not engaged in formal treatment. So does that mean that you abandon that group of people? You say, well, if you aren't gonna accept the product that I offer, I'm a doctor and I give medicines, and if you don't take medicines, then you have no role in my clinic. Not at all, or if you don't accept, anger management group, you don't belong here. Not at all. And so this is where we all need to become harm reductionists. This idea that medicine and abstinence-based psychotherapy approaches in harm reduction are these three distinct and separate entities that at some level are in conflict is a distinctly American thing. In other countries, notably Europe and Australia, harm reduction, psychotherapy and medication therapy are all one thing, right? Because they all are going in the same direction. If the fundamental pledge of being a physician is to first do no harm. So likewise, reducing harm is something that should be just a routine practice. For us, this means doing things like teaching people how to inject safely. I know as a physician, the first time I did this, it felt like I was crossing this taboo line. I was asking someone and talking to them about how they, put on a tourniquet and find a vein, and how do they clean their needles and what do they do with the sharps, and all of this stuff that felt like there was this taboo world that I, as a physician, had been tacitly told just to be like, no, you shouldn't go there, you shouldn't do that. So it was a really revelation to start doing this, and it just opened up this whole other level of relationship with patients where they actually trust you and understand, like, okay, he doesn't just care about me as a disorder that he's going to treat like kind of like a notch, like, okay, score. I'm going to fix that person and move on, where it's sort of this egocentric idea of a doctor just fixing things and moving on. Whereas it's like, okay, he's okay. Even if I reject, quote unquote, his initial treatment, he really cares about me as a person, even if it's doing this thing that using needles to inject drugs, which is so stigmatized and looked down upon. So I would encourage you all to have a close partnership with your harm reduction organizations in your community, and invite them not to be on the periphery. It's not something that you refer people to. It's something that lives and breathes in your space. So our harm reduction organization operates on site here at Highland. You stock the bathrooms with naloxone, you put sharp containers all over, you think about the waiting rooms, the cafeteria, you do harm reduction trainings for all staff, not just the ER docs, but the registration folks, the compliance people. It should be this whole culture makeover to understand drug use in a pragmatic and compassionate way, which unfortunately is this huge sort of revolution in care. One of my friends and mentors in this, Loris Maddox, she calls this no shit science, right? Because harm reduction is just not complicated. It's just being nice to people, being adaptive. There's a certain irony is that all of this work we're doing around safety net care and inclusion and equity, it really looks similar to if you were going to set up a concierge medical practice for very wealthy people. It's the same thing, where basically you're offering tailored availability, drop-in appointments, all this kind of thing, because it's what works and it's what people want. And if you really want them to get into the medical model of treatment, you have to be willing to offer this at where they're at. So please wait here. This is such a insanity. Our system of care is tragically fragmented and hostile. It's not just something where you say, okay, our system could do better. It's really awful. If you walk in the shoes of people that are trying to establish their lives after addiction, their housing, employment, insurance, legal entanglements, car tickets, medications, it is an unbelievable thicket of thorns that I just am flabbergasted, horrified at the curve that people have to get from being marginalized and not really participating in a lot of these typical administrative structures that I take for granted. To get in is so much work. Whereas once you're there, all of us on this call, most of us on this call, are going to be in a situation where many of these, I don't worry about insurance, it's done, it's filled, it's paid for by the employer. I don't have to, that kind of thing. Whereas that's just not the reality that our patients are working with. So this is where substance use navigation comes in. It's also a huge equity issue in that if you're a blind person, you need a guide. And I grew up in Redwood City, in a middle class, white Anglo family, and I'm working in a complex multicultural environment. I'm trying to do the right thing. And there's just things that I can't see, but I have insight to know that I can't see them and I need help. So what this means is that you need to build your team in that way, in that if you are trying to be anti-racist and advance equity in your practice, you need help. So you need to build a team that is comprised of people of color, and that they are empowered, that they have decision-making capacity, that they are in a leadership capacity, so that they can shape what you actually do. And it's in the absence of that, it's very, very difficult, no matter how well-intentioned you are, to actually implement equity in your practice. Now, it's a huge challenge for all of us, because all of the racial structures and discriminatory structures that have been pushing against equity for so long are baked into the whole system of how you become a nurse or become a doctor or administrator. So what we do is both, for example, Zaire and Kelvin, they come out of a program called the Mentoring in Medicine Science program, which is set up by a colleague of mine that specifically has a mission to mentor underrepresented youth into the medical profession. The Zaire is becoming a paramedic with the fire, and Kelvin is becoming a nurse. And along the way, they are substance use navigators here at Highland that help build the program. They're really on the ground helping and walking in people's shoes to negotiate all of those many, many, many interactions and gaps in the treatment and fixing them. The patients know they have power. So Zaire and Kelsa are my medical assistant delegates. So they call in prescriptions. They make appointments. It's not simply a counselor that does one-on-one work with the patient. They really have the agency and authority to shape the treatment they get, and patients see that, they respond to that. Like, oh, this is amazing. We have young, relatable people who aren't just doing what the doctor said, but they're telling the doctor what to do. And that really is an important thing to show and demonstrate in your work to promote that sense of inclusion and equity. Okay. So engagement, long-term, this is where this photo is, for me is really talking about integrating buprenorphine into your daily life, that people are going to work, they're going on trips with their family, and where does this treatment fit in terms of retention? And, it's an ongoing problem. We don't really know, how long should you be on buprenorphine? When do you go off? How often do you see the doctor? Why do some people drop out and not others? There's a huge set of questions there, and that we really are only going to be able to answer them by following those principles of engagement and listening and individually tailoring therapy to fit where people are as we go through these massive, large scale things, from COVID to, stimulus checks coming back and all of this stuff. So the way we're going to figure this out and get through this just horrible dark time of opioid mortality and COVID all coming together is by really understanding the lived experience and shaping that in a way that leads back to directing how care is constructed and implemented in all these unique communities, from yours to El Centro and the border with Mexico. So with that, oh geez, my slide got screwed up. Okay. With that, I'll sign off. That slide I'm going to send out separately is that we have an upcoming webinar looking at the role of clinicians in drug policy and discussions about criminalization versus treatment. And with that, I want to thank you for your time, and I'd love to sort of turn it over for questions.
Thank you, Dr. Herring. So we do have one question here. In your experience in using the different formulations of buprenorphine, have you found that one works better to link patients to long-term care?
Yes, I would say that the long-acting subcutaneous, the Sublocade, is really pretty amazing. It's not something you can ever direct people to, right? I mean, it's a very invasive thing. I mean, you got to imagine, right? You're letting a doctor, you're lifting your shirt and they're putting a needle and they're injecting a 30-day treatment under the skin that will limit your ability to seek pleasure and reward from opioids. You can't take it out. It's this big deal. So many people are not interested for really good reasons, but for people who are, it's kind of amazing because it takes away your craving. It takes away your the need to, I mean, I can't remember to do anything on a daily basis. You know, I don't know how, I mean, this whole concept of pill therapy that we've normalized, if you think about it, it's really complicated. You got to store them. You got to remember when to take them. It's a lot. So you release people from all that. And I've seen wonderful successes. The other thing is that it stays in your system for a long time. So if you've got 3, 4, 5, 6 months of monthly Sublocade in your system, you're going to have buprenorphine in your system for, I mean, months and months and months. You know, it'll be in your urine for 3, 4 months. So if you are going to discontinue treatment, there's no better way than to get at least 6 months of Sublocade injections. And then when you do discontinue treatment, it's going to be this very gradual process.
Thank you. And folks, I just want to remind you you can go ahead and put your questions in the chat, but we do have another one here, Dr. Herring.
Yeah.
One of the questions is, you know, what do you say to the individual who enters your emergency department for like the 6th time for an opioid overdose? How does that conversation go?
Yeah, it's a great question. So we've been, you know, background. So here at Highland, you know, we really started doing this 2017. By 2018, we're doing over 600 inductions a year. So we're seeing a lot of people. Now, you know, many thousands of people into this, and the number of people who really at any given time, like right now, you know, is there someone up at Highland who meets that description? It's actually really small. You know, there's not that many people who do that. And I can tell you that, you know, I mean, I know them all by name because they get to know everybody for good or ill. And the reality is they are incredibly high risk. They are the people who you find out that they've died. You know, you call and you talk to their brother, and you know they overdosed. So getting back to that rational decision making idea, if someone is coming back to your ER over and over and over again, there's a reason. There's something going on there, and it's really this, they need the care, you know, so they're recruiting care, but they probably need it. So we just take it as you get to know them, you become friends with them, and you just work with that friendship to pick away at what was the individual thing that drove that overdose. You know, was that you got your stuff stolen and you bought from someone you didn't know? You know, whenever you're doing overdose related counseling, you know, so you're giving them the naloxone kit and you're asking them if they've ever overdosed. At the same time, you're going to ask them about lethal means and intermingle suicide. Do you have guns at home? Do you have, you know, pills at home? Is there something, you know, if with this overdose, did you have any intention to hurt yourself, even a little? You know, we were thinking that maybe that you wouldn't wake up from this, right? Because the intersection between overdose and suicide is just so great. And then you continue, and maybe this person, you know, needs specialty medical care. Maybe they have a sort of hypoactive mania, and they're going to do great on lithium, and you're actually going to lower their risk, or who knows? So there's just a lot of work to do with those folks. And the worst thing you can do is to kind of get bored by it and frustrated and be like, oh, again, and write it off. And you have to marshal your motivation. And I'm guilty of this too, right? You see the person for the 10th time, you're like, okay, you know, this is real. You know, this is just like flipping a coin. Every time I see them, their risk of going out and dying is really high. So I'm a professional. I gotta pull my stuff together and give them the best I've got.
Excellent, thank you. A lot of pain and suffering going on there.
Yep.
Buffy, we have a few minutes for other questions. Yes.
Yes, we do.
Okay, excellent. We got Dr. Herring. We got a question from Jen. She works a lot with meth addiction, and certainly with all the fentanyl nowadays.
Yeah.
Meth. She'd like you to speak to that.
Yeah, great. So methamphetamine, I feel very much in just an ongoing learning process. I think most of us are. No one really seems to have the magic solution here. It's a really complicated situation. So what I've been really focusing on is picking off these, corners of it that are super high risk. So, for example, you just in this question mentioned the overlap of stimulant use and fentanyl use. There are some people who use methamphetamine and they get too high, or they get high and they can't come down. They stay up. Most people want to use, methamphetamine in a low dose is not euphemistically, it's a clinically performance enhancing drug. Your IQ literally goes up. If I took a little methamphetamine right now, I'd probably do a better job at this presentation. So the problem is when you use too much and for too long, you start going off the rails and you start having thought disorder and paranoia, and you reinforce that with use. And then we see all these horrible problems from the indwelling physiologic and, in terms of strokes and aortic dissections and heart failure and pulmonary hypertension, et cetera, or then there's the cognitive issues. So when people get too up, they want to come down. And so some people use opioids to come down. Right. And so there's those people who are using fentanyl as a way to come down off of methamphetamine, I feel like probably represent the highest risk people in our population. So that's a specific behavior that we've really been trying to work on, in the sense of, okay, so you're using stimulant. What can we do to keep you to get you to have the insight to choose to not use so much, you get so high. Right. And when you do what are some things you can do besides turning to fentanyl to come down? And really going after that behavior is one sort of strategy we're thinking about. Early initiation of medications for the thought disorder, being really quick to offer people things like Zyprexa, not as a diagnosis of bipolar or schizophrenia or anything long-term, but it's just to say, hey, this is a medication that when you feel your thoughts are moving too fast, this is another way to come down besides using fentanyl. So here's Zyprexa, PRN, use it as you need. As soon as they're out of that acute disordered state of psychosis and mania, then we do have tools, things like mirtazapine or Remeron, which are both provide a replacement activation if you're at the high enough dose, if you're at 30 milligrams a day, for example, to replace that just sort of loss of energy, the depression, the anhedonia, as well as help restore the architecture of sleep, which is so disrupted by stimulant use. So harm reduction, early initiation of targeted medical therapy, and then everything you got. Contingency management is really hard to do, but it works. It's easy to do contingency management that doesn't work, right? So it's a labor intensive thing, like managing all those gift cards and all that stuff. It's a big deal, but if you can pull it off, the reward with gamification, the intermittent reward piece of it, tied to medication use, tied to cognitive behavioral therapy, tied to belonging and care navigation, that's the best shot we have at limiting harm with meth use.
Excellent, thank you. I'm really glad you mentioned CM. So we have two more questions, and I'm gonna take them out of order. But how does your staff support one another? There's a lot of stuff that you're dealing with that can be pretty impactful. And how do you take care of yourself? How do you take care of one another?
That is a really smart question. And I feel like the person who asked that probably does a really good job of that in their own working life. So I think early on in my career, I happened to it happened to be lucky. Is it just when I first got out of college, and so my first employment was something called Community Connection in Santa Cruz, California. And they're a contractor of the county that provided mental health and substance use services for people with serious persistent mental illness. And the philosophy of their organization was, at that point, the term was, they were used as consumer led. So my first supervisor was a woman who openly suffered from bipolar as well as opiate use disorder. So that's just sort of how I learned to work. And the way they did that was just through this absolutely unboundaried support across between staff, a relatively flat hierarchical structure where lack of role clarity was permitted as people sort of pitched in a human-centric, agile way to get things done for people. And one of the things that I observed was, and I feel like it's been fairly consistent throughout my working life, is that the way that people treat each other as staff is how they treat their patients. So if you see a group of providers that are flexible, caring, empathetic with each other, that's probably how they treat their patients. And if you see a situation where patients are being treated in rigid, inflexible, judgmental ways, that's probably how they are with each other. It's really hard to cut those things off. So cultivating that compassion, empathy, recognizing just the human reality of just living together in a physical and mental space together is part of how you create that experience for your patients. So they're really kind of inextricable in my mind.
Thank you. I think we're up against our time. Is that correct, Grace and Buffy?
Yeah, we just hit 12:31. That was amazing.
It is. Yeah, that was that. Great. I really appreciate you coming, Dr. Herring, and presenting to us. We do have quite a few questions in our chat box, and hopefully you all stick around and we can address those questions as well as in our breakout session today. Thank you, Dr. Herring.
Great, thank you. I love it. So glad to be here, and thank you for all the work you're doing.
Okay. All right, I'm going to go ahead and get Cara your slideshow up, okay?
Okay, can everybody hear me all right? Grace, answer if you can hear me.
Yep, I got you.
Okay,
great.
I can hear you. Awesome. I feel like Dr. Herring set me up so well. I was a medical student at UCSF and actually worked as a volunteer in the chronic pain clinic at Highland Hospital in like 2012. So I've been very much influenced by all of Dr. Herring's work and everybody with the California Bridge program pretty significantly. And I think it has been the basis of my approach to addiction medicine. So I titled my presentation Moving Toward No Wrong Door, and I'm gonna try to summarize a little bit about what I think that we should aim toward in Mendocino County, and then where I think that we're at. And my disclaimer is that I've been here for 10 months. I'm an intern in the family medicine residency program that's fairly new, based at the hospital in Ukiah. I am very interested in addiction medicine, and I hope to pursue the addiction medicine fellowship after I'm done with my residency, and then come back here to Mendocino County and just keep working on all of these issues. So this is my perspective on what I've seen so far the past 10 months. And I think, as residents, we work in the inpatient setting, we work in all the outlying clinics, we work in the ER up here. We're really in a unique position where we see all of these different places, unlike almost any other provider in the community. So if you could go to the next slide, Grace.
If it will let me, let's see here. Oh, there we go. Sorry.
Okay, so we heard a lot about the Bridge program, and just to kind of introduce you guys a little bit more for those of you who aren't as familiar, all 3 of our hospitals here in Mendocino County are supposed to be Bridge sites. I will say that I think they're at different places, and I think Willits is probably the closest to more ideal model. And of course, you know, Highland Hospital is doing really well at this, and I think we're far from there. And I think some of that is particular rural challenges, you know, staffing challenges, just finding the people to do this work is hard up here. So the Bridge program has provided a lot of tools, resources, and knowledge to promote access to medication for addiction treatment in the hospital. I use it all the time. And I often find myself teaching up to a lot of the attendings here because they haven't heard of this. And it helps to really have the Bridge program website to say, look, here's a protocol. Here are some very smart people who are not interns that have said, you know, this is what we should do in these situations. So I use it a lot for that. And I think that the program, as Dr. Herring kind of said, works really well when there's this connection between outpatient care and buy-in from our inpatient providers. And I think that's where we really could improve a lot here in Mendocino County. The substance use navigators are critical for this, of shepherding people from the inpatient setting to the outpatient setting. Right now, we don't have any in Mendocino. There's job listings up for them. And I think I've heard, you know, like some murmurs about pretty soon we'll get ours up and running, but right now we don't have anybody. So there are various people who are trying to fill in those gaps, but right now there's no official substance use navigator. So the common barriers, you know, just learning a new workflow, convincing providers to do something new is hard. In our hospitals, it's the substance use navigators. And then I think it's among inpatient providers, just a lack of knowledge about outpatient resources. For how small our community is, it's amazing how little we talk to each other sometimes. So that's been a barrier that I've noticed as well. So next slide. Okay, so here's an example. When I was a medical student at UCSF, I was a total weirdo for being so interested in rural medicine. Everyone is like, oh, this is interesting. We don't know how to teach you how to do rural medicine. So I went on my own and kind of approached some of the people, Hannah Snyder at the Bridge program, and was like, can you give me a good rural example of how this program is working in Northern California? And she said, you need to go talk to these people in Placerville. So I did a project as a medical student in Placerville where I just kind of interviewed some of the people in and around that medical center, making a lot of the changes that Dr. Herring kind of talked about, the culture change things and, you know, the clinic changes and the hospital changes. And so in Placerville, I spent a lot of time with this one family doctor up there who started a clinic. They have a hospital that's not too different from ours here in Ukiah. And they had one substance use navigator and one emergency medicine provider champion. She's a PA there. And they really believe in the harm reduction philosophy. And the way that family medicine doctor put it to me about how they ran their clinic was, we are a life-saving medication and a relationship. That was what they viewed it as. And I think Dr. Herring really spoke to this in his talk. So they really welcomed walk-ins in their clinic. You know, they had some appointments, but they really tried to make it drop-in friendly. And they really try to prioritize high need patients. So they would oftentimes see people same day. You know, they would be seen in the ER, and then a substance use navigator would meet them in the ER and then just walk them down the hill to the clinic. That could totally work in Ukiah. You know, someone could be seen in our ER in Ukiah and walked across the street to our, you know, for example, our family medicine clinic or to Dr. Young's clinic. So this could totally work here. They were also using a lot of the long-acting injectable buprenorphine, which I think is also a really excellent option for rural places because many people live in communities where we don't have a pharmacy. And so just getting to the pharmacy is a challenge for a lot of folks. So next slide, please, Grace. So this is just an example of, you know, what some of the people that I talked to when I was doing my project had to say. It was a qualitative research study. So I really was interested in just how people felt about the new clinic, about how it was functioning. And so the first quote is from a 58-year-old patient who is really just speaking to this stigma problem, where they said, just it felt good being in a clinic where they were treated like a person who belonged there. And that was the most important thing for them because they had never felt that in the medical system before. And then from the MD provider, the family medicine doctor I worked with, she had originally started off trying to do addiction medicine intermixed with her primary care clinic, which is hard for a lot of reasons. And I think it is hard because of the appointment times. You tell people they get this little tiny slot, they have to be there at like 9 a.m. on a Monday, and it just doesn't work for them. And so then they kind of show up whenever, and the front desk staff gets annoyed. And, so then in those high barrier settings, people often give up. And so she felt like it was very important to have a drop-in friendly clinic. And so it just kind of speaks to, again, what Dr. Herring was saying, that this is universal. It's not just at Highland. This is in rural places too. The same issues come up. Next slide. So I think we all really need to work toward a medication first model. We want to get rid of as many hoops and barriers as we possibly can. I won't spend a ton of time on this because I think that Dr. Herring really talked about it already, but just breaking down any kind of barriers, saying that you don't need to have any lengthy assessments, you don't need to have tapering, time limits, you don't need to require therapy or any kind of program. You just want people to get and try the medicine, so that you can ultimately, hopefully, save them from overdose. Next slide. Oh, next slide, Grace. Oh, thanks. Okay, so another place that I draw a lot of inspiration from is the San Francisco Street Medicine program. So here in Ukiah, as part of the residency program, we've been really working on the street medicine program here. Some of you have worked with us a little bit. And it would be my absolute dream to make access to buprenorphine treatment a part of what we do in the street medicine program. This requires a lot of overcoming a lot of fear on the part of attendings. I'm a first-year resident, right? Like, I can't be too brazen in what I propose to people. But, it helps to have these other organizations that are doing this work that I can show to other people and explain, this is what they saw. So they did a study with Barry Zevin, published a study that, their main outcome measure was just retention and treatment. And they were just kind of following people over time. And they had retention and treatment at 1, 3, 6, 9, and 12 months of 63%, 53%, 44%, 38%, and 26%. And this is the, highest risk people, people who are unhoused, people who have severe substance use disorders, and to have a retention rate of 26% at 12 months is pretty good. So they have a webinar that's coming up on the 16th. So that's on Friday from 1 to 2. And anyone who's involved in the street medicine program or is interested in how to do really, really low barrier buprenorphine treatment should sign up for this webinar, and then should also email me because I need your help. So I think with the street medicine program, we have a lot of work to do, but our county has a pretty medium to high barrier bar for accessing buprenorphine treatment right now. And I think this could be a big opportunity for all of us. So I'd be happy to have some help with that. Okay, next slide. So then to talk a little bit about what's going on in each part of our county, I'll start in Ukiah because that's the area I know the most about, and that's where I mostly work. So I would say most of our ED providers are very comfortable treating opioid use disorder with buprenorphine. We are really fortunate in that a lot of our providers trained at Highland with Dr. Herring, so they have approached me, and I've talked to a few of them about how to improve access to care and kind of the transition between inpatient and outpatient. So I think a lot of people are on board with starting the medicine. That's barrier is done, but they can start the medicine and then what? Like what happens after that? So right now the workflow is essentially to hand them the phone number for either Dr. Young, who works at the Rural Health Center next door to my clinic here in Hospital Drive, or the phone number to MCHC, which has had a really long-standing, buprenorphine program for a while. And then you just kind of hope that they call. You hope that they have a cell phone. You hope that they don't lose the piece of paper. You hope that there aren't other pressing things that, are getting in the way, like trying to find housing or a safe place to sleep or managing the infection that brought them to the ER in the first place. So I think that's really not ideal. We don't have a warm handoff right now because we don't have a substance use navigator. And I think our case management department is overwhelmed by a lot of other tasks. And so I think this is a place that could definitely be improved. And then the other thing is the family medicine residency clinic. We are expanding rapidly. And I think we're thinking about ways that we can also help support, the other buprenorphine providers in the community and trying to make the residency more drop-in friendly. But like everybody else in this county, there hasn't been enough access to care for a long, long time. And so our schedules get packed with primary care. So it's going to be figuring out what the ideal workflow would be over time, but that's something I'm hoping for. Next slide. Before actually we go to the next slide, one thing also I want to say is McCavan is here in Ukiah. That's the Mendocino County AIDS and Viral Hepatitis Network. That's where Grace works. They are our harm reduction agency. Everything harm reduction related in Mendocino County is McCavan. They've been operating since the 80s. I go to them for a lot of things, like for help with, navigating, patient care with really severe substance use patients, and for the syringe exchange. They run the syringe exchange here in Ukiah. So if you are interested in getting more resources about safe injection and things like that, McCavan is your local resource for that.
We also cover all of Mendocino County. So if you're coastal, inland, and I can put my email in the chat if anybody.
Yes, definitely.
Thanks,
Oh yeah, of course. Always happy to shout out you guys. I mean, to have a rural county with a harm reduction agency that's been running since the 1980s is very, very unusual. So we're super lucky. I will say that in Placerville in El Dorado County, they did not have anything like McCavan. Okay, next slide. So Willits. Okay, I think Willits is doing better in terms of connecting people from the ER to outpatient care. They have a really solid team up there, Dr. Glyer, Dr. McCullough, Dr. Patrincio, Sam Cahill. I got to go to one of their meetings when I was sort of like doing reconnaissance for this talk. And they are working on group visits. They really try to prioritize seeing patients from the ED or the hospital, like either same day or within 24 hours. They have, some people who are doing care coordination. I think it's working really well. One question I have is a lot of people end up in their ER who have overdosed and are from, say Covelo or Laytonville. And how do we support those patients? Because it's a barrier to drive for a follow-up appointment in Willits if you came from Covelo. So we need to think about that a little bit more too. So next slide. Okay, now we're going into the places where I have less knowledge. Fort Bragg and the coast. I surveyed some of the residents who I know have rotated out in Fort Bragg in the ER in the hospital setting. And I asked them, I was like, is anybody doing buprenorphine in the ER out there? What's going on? And they tell me a few people have X waivers. They haven't seen anybody use them, which is a bummer. And it might be, it might be better than I know. But I think in the hospital setting, we have a long way to go. And then in the clinic outpatient setting, there's Mendocino Coast Clinics, there's RCMS or RCMC, there's Mendonoma Health Alliance. They're a great resource out on the coast. So I think outpatient wise, we're making more headway than we are inpatient wise. And there's probably more resources that I just simply don't know about because I'm pretty new here. Next slide. Okay, so the other outlying areas. So I have rotated in Anderson Valley and Round Valley Health Centers. So I know a little bit about what's going on in those places. Long Valley up in Laytonville, I have not been there yet. So there could be resources there that I don't know about. In Anderson Valley, all of the providers there are X-waivered and they are doing inductions. So if anybody is in, the Anderson Valley area, they can present to the clinic there and they can do an induction. I think different providers there have different comfort levels though. And so their protocols are going to kind of vary. I think that a place for improvement would be trying to have all of our clinics have a really low barrier approach. And I think, just people's comfort level is different. And so I think that's something we can work on also as a group. And then in Round Valley, Dr. Trotter is working with the Round Valley Indian Tribes and Ukiah Trails to be their map access provider. And I think that they're just doing an excellent job of building up their program. And I think one thing that I heard from them up there is that they would be interested in better coordination of care with the Willits ED for those patients who overdose. But Dr. Trotter is working really hard with Ukiah Trails to try and get a solid program up there. One interesting thing about Anderson Valley and Round Valley is they both have their the ability to get medications sent to their clinics. So they kind of overcome the barrier of not having a pharmacy in their community. And I know Anderson Valley, they have buprenorphine on site, so they can give people treatment on site. And then Round Valley does not have that yet, but they can get medication brought to them from Myers Pharmacy within 24 hours. So that's another barrier that we have. That's a situation in which I think, long-acting injectable buprenorphine could be really helpful. Okay, next slide. So to summarize, I think some of the barriers that we're facing here in our county, which are not unique to Mendocino County necessarily, it's, common barriers of distance are happen in a lot of rural places. But here, I think we struggle with some poor communication between the hospital and the clinics. There's a lot of the providers who don't do this type of work very often. I think there's some fear of the DEA or fear of diversion in providing low barrier access points. And then I think that the most insidious barrier is assuming that people who use drugs aren't interested in treatment. And you often hear in the hospital, especially, I hear providers say things like, oh, they just keep coming back, like they aren't interested. And I think the real question is to be like, what is standing in the way? What is going on in this person's life? What can we support? How can we have a more harm reduction lens when we're trying to help this person? Other things are more pressing medical issues that divert the provider's attention. People don't think it's their job to treat addiction. They're like, oh, they're here for their heart failure. I'm not going to talk about their addiction problems, even though maybe their addiction problems is the cause of their heart failure. There's just a lack of familiarity with the different treatment options. And then, patients, for some of them, they're unable to adhere to our traditional high barrier medical models of care. And so we need to bring treatment to people. So last slide is the next one. For me, I think as a resident, I just feel like there are so many opportunities for improvement here. Sometimes when you hear about what's going on at Highland Hospital, you're like, oh, wow, that's so great. How are we ever going to get there as our, rural county with so many issues and not as many resources, and all of our people are so spread out. But I am really trying to view it as an opportunity. And I'm so excited to be here in this moment where the things that I am very, very interested in working on, which is primary care and rural addiction medicine, is something that I'm finding a lot of people are excited about. I'm committed to staying here in this community, so I will be working on this for decades to come. And, I'm grateful for the Bridge program and for UCSF for providing me a lot of resources that I can rely on and bring to my attendings up here. And then I think there are a lot of really exciting things that are coming up. I think the residency program is going to facilitate communication between a lot of different clinics and a lot of different settings, because we go everywhere. We go to the coast, we go up north, we work in Ukiah, we work inpatient, we work outpatient. So I think in that way, just by nature of us going to all these places, we can spread information faster. And then I think there are some projects in the works for low barrier access points, both through the syringe exchange at McCavan and through street medicine program. And then I know we're going to hear about the new clinic at Pinoleville too. So I'm sure there's lots of stuff going on in the county that I don't know about, and I would love to hear from people. So my email address is on there. feel free to email me if you have a project, if you want to collaborate, if you want to help me with any of my projects. I'd love to hear about it. And I'm grateful for the opportunity to talk to everybody today.
Thank you, Cara. I'm just going to add, we are going to start a low barrier MAP program at McCavan, which might help bridge some of the gaps in the more rural areas. So definitely stay tuned for that. We've got it in the works. We were going to do some breakout rooms talking about creating transitions of care service and care mapping service. And if you wanted to enter some questions in the chat, you can, but we've got 3 questions that we were going to get you started with. Buffy, do you want me to enter them into the chat now or break everybody out, or?
I think when you break us out that we won't see it in the chat. So you'll have to break us out and then put it, and then come to each chat and put them in.
Okay. All right. So everyone prepare to be transported to these fancy breakout rooms. We are going to make Hi, everybody. Did you guys see the questions? I'm not sure if someone entered them for you already. Okay, I think we're all back from what I can see here. All right. How was that? Do we have some good discussions? Yeah, good. Okay. The last thing on the agenda was just if there's any questions to Cara or discussions, or if Cara wanted to add anything else, or that's what we had for this last 10 minutes.
And Grace, we were also going to share out from what we learned in our breakouts.
Oh, totally, which I don't have written here, but thank you. So yeah, share who wants to go first. Thanks for bearing with me.
I can share a couple insights from our breakout session.
Great.
There, one thing that I hadn't considered, which is a huge thing, is a barrier to treatment in our area is for adolescents. So people like one of the people in the breakout session mentioned, a 17-year-old that needed treatment, but there's no inpatient treatment for him. He has to go all the way down to LA. So I feel like that's a huge consideration that we have to address or try to improve in our area, because it sounds like he wants help, he just can't get it, and that's heartbreaking. Another thing was trying to find a safe place for people to go before they can go into treatment, because there's usually a gap of time there. Lisa mentioned that there is the room key program that can help some. It's not available in all areas, but trying to also work on places where people can stay, and increasing like social support for people even in between that time can be huge. And if I'm forgetting anything, I feel like I'm forgetting a whole bunch of stuff, but I don't know if anybody in that session had anything else that they remembered that we just talked about.
Thank you, Joanne.
Thank you, Joanne.
Anybody else want to share? I think we had 6 rooms, so.
Adrian, why don't you introduce yourself?
I was just about to. My name is Adrian, and I am a VISTA community service volunteer from AmeriCorps, and I took notes for our group, and we found that some of the biggest barriers that we were having were making the appointments and actually keeping them. And that maybe having a 7-day drop-in clinic would work better. And another one of the biggest problems were living in rural areas and getting people to those appointments or getting help to those people. And figuring out another issue was phones. People don't have phones to we can get a hold of them, or they can't call in to let people know or where they're at, where they're staying. Some don't have cars, some don't have rides. Just how to figure out those issues and get, treatment to them. And then, and then we have we just had discussions on new clinics that were in the works and in the different areas. And I think that's all that I have.
Well, to answer a little bit or maybe provide some future hope, we are going to be a drop-in center for folks that want MAT. And we also will be providing transport throughout the county through our Clara office, but we'll be doing outreach. So hopefully we can start bridging some of those access issues through McCabe. Okay. Anybody else want to share?
We had talked about the difficulty for different recovery programs in the area that would take dual diagnosis folks, which is really difficult. Just getting them treated and also being able to, when they're coming off the drugs, being able to then see kind of where they're at and help to stabilize them with the medication at that point is really difficult.
In our group, we talked about that as providers, we're unaware of all the resources across Mendocino County, or even in terms of MAT treatment, like what's culturally appropriate for this person or what is in their neighborhood. We talked about how there used to be the idea of the 211 number, that anyone could call a 211 number and there would be information on there, but that it hasn't been up and running, partly maybe because of funding problems. We talked about maybe one way to let people know about the resources is word of mouth. So if you talk to one client about what you know is available, then they can talk to other people that they know. Another barrier to care was if you have a primary care provider, that might not be the person you want to talk to. You don't feel comfortable talking to them about substance use issues. And some providers don't, if you already have a provider, they may not be an addiction treatment provider. Again, no centralized hub or directory for you to know about resources or get referrals to people. At our clinic, you have to be an established member of our clinic in order to get substance use care. And so if you're going to another clinic, you can't come to our clinic for care. We definitely talked about more flexibility and trying to get drop-in centers and providers having drop-in availability would be very helpful. And again, the phone number problem. In terms of transportation, I know that we have gas cards that we'll give people when they come to their appointments. So that's one thing that helps with the transportation partly. Some successes in bridging access care drops would be the drop-in center, having pharmacies nearby or availability of medications at the clinic. Getting the medications paid for by the bridge program is one way to overcome that barrier. Having our pharmacy right next to our clinic is helpful. And being able to get communication, like at Ukiah, they could sometimes start in the ER and then the care management would talk directly to Mendocino Coast Clinic about getting them an appointment. And that was helpful. And so increasing communication between providers would be helpful. Getting the substance use navigators back would be helpful. Getting more information about harm reduction out to providers and more education to everyone who's client facing. And I think that's it.
Libby, actually, sorry, our executive director, Libby at McCavan, she is going to be providing presentations to providers, to anybody who would like that regarding harm reduction. So she's at jury duty, or she was, and now she has to run back. But I just wanted to answer that one question. So thank you so much. I think we're right at time, Buffy. Do we want to take any more? Or?
All right. Yeah, we are out of time. And I just wanted to say thank you everyone for coming, and a big round of applause for our presenters today. Yeah. That was just amazing. Lots of information today. If you're interested in joining the SafeRx Coalition, please reach out to us. You know, you could send me an email. I'll post it again in the chat box. Our next meeting is tomorrow at 9 a.m. We meet the third Thursdays of the month at 9 a.m. If you have any, need linkages to providers in the county, please reach out to us. And we are working feverishly trying to come up with some ideas on how to create a dashboard or put it on the website for SafeRx, where you can actually look and see not just where the MAT providers are, but what services they offer and things like that to help us link services better. And hopefully we see you all next week.
Yes.
That's all I got. Thank you.
Thank you, everybody.
Bye.
Thanks for bearing with technical things too.
Bye, thanks.
Bye. All right.
All right.